We can all agree. All right, fasten your seatbelts. We're going to go where we disagree, because we're going to start talking about cost and reimbursement. And as I said, we've got a bomb thrower to my right, which I just think is great on a broadcast like this. So I'm going to go that way first. When you look at the cost of these oral versus the IV oncolytics, we've talked about the fact that there are fixed costs that are attendant upon the IV administration, which is you need an office, you need a staff, you need all of this overhead. And when you consider the cost of oral versus IV oncolytics from a payer standpoint, or from anyone's standpoint, is this being factored in?
So from my perspective, my physicians have no idea what makes money and what doesn't. They don't know. So from
surprise. Most physicians I know think they're great economists, and they are terrible.
We are terrible.
No, from my perspective, it's the right drug for the right patient at the right time.
Okay.
And so regardless of whether it's intravenous or oral, I want to make sure that my patient's getting the right therapy for them. And so when I look at the cost overall, certainly, you know, as I mentioned earlier, using an oral agent may be less financially attractive, you know, to the practice overall, because we're not reimbursed for the management of that oral agent, whereas for intravenous agents, as you point out, you know, we get an administration fee and so forth. So certainly there are advantages on the intravenous side versus the oral side, maybe from a reimbursement standpoint, if the physician doesn't have control over dispensing that oral oncolytic. To be fully transparent, if you have an in-office dispensing program, just like the specialty pharmacies, you're going to make money doing that service.
I mean,
Yeah.
But at the same time, we will give patients cash transactions for drugs that they might have to go to Walgreens or another specialty pharmacy and pay cash for. We know that an aromatase inhibitor costs $2, where the specialty pharmacy or the retail pharmacy may be costing the patient $30 or $40.
Wow.
So we'll just dispense it to the patient for $5 in our office. Patient avoids that larger cost, and we're monitoring the patient. So just another way to go about it.
but my point was, there's an embedded cost in the IV. The embedded cost is the
Facility. The
and
nursing.
keeping it going.
Staff,
Right.
equipment, everything.
And again, there's the economy of scale, because that facility is treating lots of patients per day. But still, it's an additional cost. So when you tell me it's $30,000 a month for the pills and the IV's cheaper, that's just the drug cost, right? Then you have to add in all of this ancillary stuff. Where does that balance out? And are people doing that bookkeeping other than behind the closed doors at the insurance company?
Well, you know, I think some physicians that have relied on IV chemotherapies that don't have dispensing pharmacies tend to use more IVs because of that. And some of them admit it. They admit it on advisory boards that I've been to. And I mean, it's surprising to hear that, but you do hear that from some people.
Yeah, I mean, I have definitely heard that from people, but I think at the end of the day, physicians want to make their patients happy, because big picture, that's how they're going to keep coming back to them. And you have to have a good referral base, and if your patient is happy, they're going to refer to you, and you're going to do well. And I think physicians know that overall, that the first priority is the patient and the quality of life.
Okay, let me put something on the table. And again, it's looking at this from a payer's standpoint, right? If the physician's only concern, maybe it should be the only concern, is the patient's well-being. And I've got a therapy that costs $1 trillion per pill. It's going to be great for you. You need that. Well, you do that enough, you break the bank, and the country goes bankrupt, right? Don't we have a responsibility to be at least cost efficient here?
We do, and I mean, it's actually one of the things, we're part of Regional Cancer Care Associates, which is actually based initially in Hackensack and spread throughout New Jersey and some other states as well. And one of the things that we're looking at is, following guidelines, following best practice, but keeping the cost down. So if there's two equally effective drugs, but one is less expensive, to use those drugs. And insurance companies are looking at the costs for that physicians, how much the physician costs the system, how many scans they're doing, how much, how expensive are the drugs that they're doing, how frequently are their patients ending up in the hospital. And so, those are things that will become more important
yeah, exactly.
in the future.
And I think now payers are in the like now with precision oncology, they're really looking into that, and they're making tiers for compensation. So even if you're in network, if you're not following best practices or pathways or certain benchmarks that they're establishing, they will compensate you differently. So there's different facilities will pay you differently, even with the same plan.